Colorful logos and blue text on a white background. Aspire. Together, we're better. In partnership with Disability Lead. Building disability equity in healthcare. Orange, blue, and pink chevrons wipe over the title. At center, a welcome slide with logos and title. At right, a mini video of the speaker. As panelists are introduced, view shifts to show speaker in whole screen.
Hello, welcome to Building Disability Equity in Healthcare, presented in partnership by Aspire and Disability Lead. My name is Claire Killey. I use she, her pronouns, and I'm the Director of Inclusive Solutions here at Aspire. I'd like to provide a brief image description by letting you know that I am a white woman with long, dark brown hair. I'm wearing a blue shirt with a black blazer. Behind me is an image of the front lobby of Aspire's Weinberg Career Academy. Over one of my shoulders is a front desk and welcome sign, and over my other shoulder is a long brick wall with 2 chairs beside a small table with a vase of flowers. Image descriptions are an inclusive best practice for people who are blind, have low vision, or unable to access a screen. Each of our participants today will be providing one for you. Thank you all for joining us for today's program as we seek to do 3 things: raise awareness, share knowledge, and invite advocacy on the topic of quality healthcare for people with disabilities. We're thrilled to have had over 350 registrants for today's program, including representatives from Illinois Congressman Mike Quigley's office. We're so grateful to have every single one of you here with us today. For those of you new to Aspire, we are a leading nonprofit organization that is defining what it means to be radically inclusive. We ask you to join us in our movement to change how society includes and empowers people with disabilities. You can learn more about us at aspirechicago.com. We're bringing you today's event in collaboration with another local nonprofit, Disability Lead, which is a network of people with disabilities who use their power to create an equitable and inclusive society. If you are a person with a disability living in the Chicago region and you're interested in joining their community, visit disabilitylead.org to become a member or a fellow in their 2022 Institute. We are so honored to share that all 3 of our panelists are members of Disability Lead's network. At this time, I am thrilled to introduce our panelists and moderator for today's conversation. First off, I'd like to welcome our first panelist, Andres Gallegos. Andres is a national healthcare attorney and shareholder with the Chicago-based law firm Robbins, Solomon and Pat Limited. He founded and directs the law firm's national disability rights practice, which focuses on improving access to healthcare and wellness programs for persons across all categories of disability. Andres was named chairman of the National Council on Disability by President Biden on January 20th, 2021. Andres, please share your pronouns and provide a brief image description.
Good afternoon. My pronouns are he and his. I am a Hispanic male of fair complexion, exceedingly gray hair. I'm wearing black squared glasses. I have on a white shirt with a gold and black plaid Burberry tie and a black suit jacket. And I'm speaking to you from my home office.
Great. Thank you. We're so glad to have you with us, Andres.
Please.
Next, I'd like to welcome LaShawn Garola. LaShawn is a registered nurse care manager at Rush University Medical Center, working with vulnerable populations. She is knowledgeable on health equity because she sees the impact when health equity and access to care is lacking in vulnerable communities. LaShawn advocates and teaches others how to advocate for themselves with their care team. LaShawn, please share your pronouns and provide a brief image description.
Thank you, Claire. Good afternoon, everyone. My pronouns would be she, her, and hers. I am an African-American female. I am dark complected. I have medium length hair that is curly. I am wearing a maroon jumpsuit covered by my work lab coat. I have reading glasses with purple frame. I'm sitting in my office. The background is with the shade pulled down, and thank you for having me.
Thank you, LaShawn. Next, I'd like to welcome Renee Patrick. Renee is a director with the Division of Rehabilitation Services at the Illinois Department of Human Services. Renee is leading equitable employment for people with disabilities, which is a key component of health equity. The need for access for people with disabilities has been a driver in her career. Renee holds a Master of Arts in Industrial and Organizational Psychology. Please share your pronouns and provide a brief image description.
Hi, my pronouns are she and they, and I have dark curly hair that's shoulder length. I'm Thai and white with fair complexion, and I have circle glasses, and I'm wearing a peach seersucker suit with a peach blouse underneath.
Great, thank you. Glad to have you with us as well. All right, and finally, I'd like to welcome our moderator and my colleague from Aspire, Kristen Kroc, to join me on screen. Kristen is the Director of Life Enrichment at Aspire and has been working with people with disabilities for over 25 years. She has experience in direct care, program management, and program development. She's overseen the development and expansion of health promotion programs at Aspire while promoting wellness for individuals served. Kristen, I'll invite you to share your pronouns, a brief image description, and then you have the floor until I return for some closing remarks. So I hope you all have a great conversation.
Great, thank you, Claire. Hello and welcome, everyone. As Claire mentioned, my name is Kristen Kroc. I use she, her pronouns, and I'd like to provide you an image description by letting you know that I'm a white woman with shoulder length blonde hair. I am wearing glasses today, they're purple, and I have on a blue colored shirt. Behind me is an image of the Aspire Weinberg Career Academy. Over my shoulder is a lime green wall, and over my other shoulder is a white wall with 2 gray couches. I need to let everybody know I am in an office space where the lights are going to go off automatically if I don't move around. So I really apologize if it's distracting. I'm trying to discreetly move so that the lights aren't shutting off on me, but I know that it's distracting on video. So I'm going to do my best with that situation. So thank you. I am thrilled to have the opportunity to spend time with our dynamic panelists today and be a part of this discussion. Health and wellness has been and continues to be an essential component of Aspire's mission. We're here today because we know that there are significant disparities in healthcare, specifically for individuals with disabilities. For our purposes today, we want to spend some time highlighting the challenges while focusing the majority of our time on solutions that we can all be a part of. Before we begin our conversation, I want to take a moment to establish a safe space for both our panelists and our audience. Each of us brings valuable and unique perspectives to the table. So let's enter our conversation today with shared respect and intention to learn from one another. Each of our panelists are connected to this topic of healthcare and the disability community in different ways. So to get us started, I'd like to give each of you a moment to briefly connect the topic today with your professional work. Andres, let's start with you. How does healthcare access directly relate to disability rights from a legal perspective?
So, Kristen, thank you for the question. 48 years ago, the first federal civil rights legislation was passed in the form of Section 504 of the Rehabilitation Act of 1973, which prohibited entities from receive federal financial assistance, like hospitals and other healthcare facilities, and healthcare providers that participate in Medicare and Medicaid, from discriminating against us based on our disabilities. 31 years ago, those civil rights were expanded considerably when the Americans with Disabilities Act was passed. And that contains an overarching obligation for healthcare facilities and providers to ensure that people with disabilities receive an equal opportunity to benefit from their healthcare services as persons who are not disabled. 11 years ago, with the passage of the Affordable Care Act, Similar civil rights legislation was passed in its section 1557, which again prohibits discrimination based on disability by healthcare providers. So, Kristen, you have a trio of federal legislation that not only creates a legal but a civil right for persons with disabilities to receive accessible healthcare. And the absence of receiving accessible healthcare is a violation of those civil and legal rights. And violations are actionable under one or all of these federal statutes, actionable by persons whose rights have been denied. Each of the three federal statutes that grant us protection from non-discrimination also give us the right to enforce those laws on our own. And that can be done by initiating a complaint with Department of Justice, Department of Health and Human Services, or by filing complaints with our respective Departments of Human Rights, or filing federal lawsuits to protect those rights. So that's a long way of saying that healthcare access directly relates to disability rights, and disability rights include the right to access healthcare.
Thank you, Andres. LaShawn, as a medical professional with a disability, you really focused on patient self-advocacy. So can you talk about why that is so important?
Thank you, Kristen. So patient self-advocacy is very important. As a patient, we have to get comfortable and accustomed to using our voices to request, ask, and demand for what it is that we need. As a patient, you know, the care is centered around you. And a lot of times people mistakenly view the relationship between being a patient and the healthcare provider as a them versus us type of relationship. But in all actuality, it is a partnership that needs to be established. When you advocate for yourself, you are not necessarily reacting to something negative that you need to fix, although that can sometimes happen. But what it is establishing that relationship with the care team so that they know you are present, not only physically, but mentally present. You get used to using your voice. If you want a second opinion, you will be able to ask for that without feeling repercussions or that the provider may get upset with you. You may just have health concerns or questions that you want addressed. So being comfortable and having that open dialogue relationship with your provider is a minimal way of advocacy. But who better to know what you need but you? If you're unable or in a situation that you can't relay that for yourself, then typically people will designate someone to do that. But when you're able to do it for yourself, it is best to do that because you want to be able to feel like the care that you're receiving is centered around you, it is designed for you, and it is to help you. And when you don't feel like you have a voice, you can kind of maybe get a little complacent with it and not follow up or follow through. So self-advocacy is one of the most basic ways that we exert our rights as a human and as an individual. It is critical and key to improving our health outcomes when we advocate for ourselves. It is very different. We're all in different situations, whether you are a person with a disability or not. We're all in unique situations, but who best can relay your situation and your needs but you?
LaShawn, thank you. Renee, your focus is primarily around employment. So help us understand how healthcare relates to employment for people with disabilities.
Yeah, thank you. So employment actually is critical for folks with disabilities because it is part of like the human experience. To be employed is something that is very natural. And it actually can be part of improving your health when you are employed. Yeah, many times though, you do need health care to be able to be engaged in employment. So things like being able to get in-home assistance, being bathed, taking care of your home, seeing your doctor on a regular basis, all of those components are necessary for you to be able to engage in the workforce. people with disabilities are unemployed at a higher rate than people without disabilities. And why is there that disparity? There's a lot of barriers that are imposed on people with disabilities and limits to healthcare in terms access, in terms of like maintaining a level of poverty, those sort of barriers. I mean, those can be barriers that were set to keep the population of people using public programs for health insurance small. But the impact is that then when people do want to work, they're not able to keep on the healthcare programs that are necessary for them to be employed. So there's this connection that's very, very essential for people with disabilities between employment and healthcare.
Thank you, Rani. Thank you, panelists, for connecting our topic today to your professional work, as it really models the different layers of health equity and its impact on our personal and professional lives, as you all just stated and demonstrated. I understand that each of you identify as having a disability. And on a personal note, I'm hoping you might share one example of a time when you've personally experienced discrimination in healthcare. Andres shared a few examples while on the podcast, but LaShawn or Rani, would you like to share? LaShawn?
Thank you, Kristen. I can share an instance. Yes, thank you. In 2019, I was hospitalized for 4 days, and the physicians put me on a new medication to treat my lupus condition. I went home, or went to the pharmacy rather, to get the medication, the prescription filled. The pharmacist asked me if I was a transplant patient, to which I said no. Then the pharmacist told me that, well, I'll order you some medication. It'll take 3 days to get here. You can come back in 3 days because the stock that I have, I'm going to keep it for transplant patients. I was dumbfounded. I felt like, okay, based on my medical condition, my disability, I don't have access to this medication. And as Rani mentioned, I work, I'm employed, I have health insurance, but yet somehow I didn't have access to this drug. I had to advocate for myself, which I help other patients do. And it was a Sunday. This was a Sunday afternoon, 1 p.m. when all this started. So immediately I did leave the pharmacy, and I emailed the administrator at the place of employment and explained the situation. And I didn't realize it at the time that there are actually plan administrators that companies have that pick the plans and oversee. And I explained, I work, I have insurance, I cannot get this medication. They're telling me it's a specialty drug, which I didn't know. And how as a patient, I was to be readmitted within the next day if I didn't get this medication. So long story short, it took me till 8 p.m. between working with the administrator at the hospital and the plan administrator to do an override for me to then go back and have access to this medication. But I felt I was discriminated because I had a different condition that this pharmacist felt like I could wait 3 days for this medication that was keeping me out of the hospital.
Thank you, LaShawn, for sharing that story. Rani?
Yep. So I have arthritis. I've had arthritis since I was 10 years old, and I first also had psoriasis diagnosed at the age of 8. And then, like in my teen years, I probably started having depression. So with all of these type of disabilities, well, the psoriasis and arthritis, they're both progressive. So over time, it became more difficult for me to move around and use my joints. And, I've had different experiences where, as a teenager, a dermatologist assumed that because I have psoriasis, that the employment opportunities that I had, that I probably couldn't work in a restaurant because I had psoriasis. So, here in a hospital bed, I'm sitting in a hospital bed as a teenager, not really sure about my own future, my capabilities, and here a doctor who I respect is telling me that this certain employment avenue is not going to be for me. And then, as I got older, I start using a wheelchair, and access to a mammogram was not made available to me because of, there's a mammogram, the machines were not at the time made so that they would allow me to stay seated and be able to check for breast health. So those are two examples that are pretty stark and stay in my mind to this day.
Thank you, Runny and LaShawn, for sharing those stories. I really appreciate the vulnerability you brought to this conversation by sharing those experiences with us. Andres, during your recent interview on Aspire's podcast with Claire, you emphasized the importance of disability cultural competency for medical professionals. Can you briefly describe what that means and how it impacts the patient experience?
Well, look, it's how it impacts the patient experiences is really to address the problems that Rani mentioned that she experienced. The fact that women with disabilities, women primarily with mobility disabilities who use mobility devices that can't independently stand or transfer themselves, are denied care and treatment because they can't access diagnostic equipment, right? So what disability cultural competency means, it's really providing healthcare services to people with disabilities that respects their disabilities by healthcare providers that are knowledgeable and understand what our disability means, and that care and treatment is designed to address the uniqueness of our disabilities, discerning between specific disabilities. For example, there are varying causes for paralysis and mobility disabilities, from spinal cord injuries, which I have, to cerebral palsy, to stroke, etc. And each of those underlying conditions do require different care, treatment, and support. So having physicians that are formally trained and receive disability cultural competency training in medical schools, in residencies, and in fellowships makes a significant difference in the patient experience. It creates a more welcoming environment within the healthcare for people with disabilities, where today it is not. As many of you know, in February of this year, Dr. Lisa Iazzoni and her colleagues published a study in Health Affairs that revealed that over 82% of physicians surveyed nationwide believe that people with significant disabilities have a lower quality of life than people without disabilities. And that belief guides their clinical decision-making in determining treatments, plan of care, referral services. So it truly provides data to the adage, how they see us is how they treat us. And we saw how deadly those negative attitudes are about people with disabilities during the height of the pandemic, when healthcare systems and hospitals adopted and invoked crisis standards of care and medical rationing policies that unabashedly discriminated against us simply because of having disabilities. So education addresses a significant amount of ignorance. However, at the end of the day, we have to find a way to change healthcare providers' hearts with respect to how they feel about people with disabilities. But disability cultural competency, formally provided in medical schools, I think begins to address that.
Thank you, Andres. This is such an integral part and piece of the patient experience we've been talking about, as well as a really necessary component of the education and ongoing training of health professionals, which you do talk about more in the podcast, specifically as it relates to the National Council on Disability. So thank you for that. Okay, we want to spend the bulk of our time focusing on solutions and how each of us can support progress. So let's first take a moment to define what we're striving towards collectively. And we recognize that equity is complex and it's unique to each individual, but we would like to have your help to help us explain what it means to you. So what are 3 traits you would use to describe what true equity in healthcare should look like for people with disabilities? Rani, I'm going to start with you.
Well, I would say multiracial, efficient, and welcoming.
Do you feel that those, I mean, obviously they all tie together, but can you maybe kind of do that with us and for us and tie those traits together?
I wasn't.
That's okay.
Well, so I mean, it's to me, it's all about inclusion, and it's really talking about what Andres is talking about. No one that's getting services, disabled or not, should have a feeling that they should sacrifice themselves when they need some sort of health service. So, you know, multiracial. I'm a multiple racial person. That my one parent was born in a country that has been categorized as a lower class country from the United States. And so that is not equitable from the jump. And so when we're talking about equity, people should feel that they're going to be valued regardless of what their racial background is, what their disability type is, whether or not they are what their economic status is, and so that's why I talked about multiracial, that it's efficient, so it's not like you're waiting for approvals for a really long time, that you know you're available to be eligible, and then also that ultimately that it's all welcoming. So I'm having a hard time, like, you know, getting to tie it all together, but that's the best I could do, Kristen.
I think you did exactly that. You did bring those together. So thank you very much. LaShawn.
Sure, thanks, Kristen. So 3 traits that come to mind would be obviously quality. And when I say the word quality, I'm meaning optimal care that is competent. And when I say competent, I'm meaning culturally competent, clinically and medically competent. As Rani is saying, diversity is when we have providers that are educated in that and how that looks, because care needs to be specific. So what's quality for me may not necessarily be quality for someone else. It's going to be based on my needs and my concerns and what I need. Transformational comes to mind, meaning to change the current state of healthcare to a better state for people with disabilities. And what does that look like? Andres talked a little bit about that, as well as Rani. We don't want our care to be burdensome or feel like we are getting substandard care because we can't utilize diagnostics, or we can't get our pap smear because we can't jump up on the table from the wheelchair, or whatever the situation may be. So there still needs to be change. And I think part of that is identifying demographically, especially in a case like myself, where I have an invisible disability per se. Most days you can't tell, but some days you can tell. When we identify, I think that serves purposes. And one of the biggest purpose that can serve when we talk about transformational is that we can get accurate data that will help improve our outcomes as a person with a disability. When they're just sitting there seeing me as an African-American female, age this, weight this, and the typical demographic, without that piece of how I identify with my disability, to understand what that entails for me and where I expect my outcomes to go based on that. Does that make sense? And then my third one would be seamless. historically, health systems and organizations, insurance, the whole surrounding settings, the adjustments that we need hasn't always been there. When we talk about health outcomes, I don't believe a disability equals poor health or poor health outcomes. What I believe is that the physical and social barriers haven't been addressed and they keep us at a disadvantage. So when care is seamless, all of that is taken into consideration. So I don't feel like a burden. I don't feel like I'm asking for something extraordinary to have quality care. And those are my traits.
Thank you, LaShawn. Andres.
So really, I want to echo what both Ronnie and Lashana just mentioned. So 3 traits, I'm thinking of compliant, I'm thinking of quality, and I'm thinking of inclusiveness. So compliant, strict compliance with the minimum guidelines for barrier removal requirements and the modifications to policies and procedures that are required under the Americans with Disabilities Act. Again, we just celebrated the 31st anniversary of the Americans with Disabilities Act, but there are still an overwhelming number of healthcare providers that seem not to know what their legal obligations are. So compliance has to be one of those characteristics. Number 2, quality. And quality goes back to the adoption and implementation of disability competent cultural curricula in all medical, dental, behavioral health, nursing, and all of the medical and health professionals and allied health professional schools, in residency and fellowship programs. I truly believe that education is going to make a difference on the quality of care that people with disabilities receive. There are physicians that are board certified in a number of different specialties that will not even see or treat a patient with a disabilities, but nevertheless be certified in that particular specialty, and that has to change. And number 3, again, inclusivity, but a different aspect of inclusivity, and that is that people with disabilities need to be representative and seated on boards of healthcare systems and on hospitals where decisions are being made, where programs are being designed, so that we have a seat at the table and we're seen not as just members of the community, but as people that have equal importance and significance by being a board member, as opposed to an auxiliary board member that just provides advice and guidance occasionally. So those 3 things.
Thank you, Andres and panelists. Some of the comments or some of the traits that I heard or words that I heard, traits were inclusiveness, quality, compliance, transformational, some really great words. And I feel that those traits provide us with a framework for conversations moving forward so that we can really do something about changing the paradigm as it pertains to health equity for people with disabilities. Our next question comes from an audience member who submitted the following question. Health inequity has existed in our population for so many years. How do we stop talking about it and really do something about it? So thank you for the submission. And to this point, panelists, what are some calls to action for our audience today in terms of concrete, tangible action steps to support health equity? And LaShawn, I'm going to have you go first.
Thank you, Kristen. So when thinking about this one, I think that old cliche, it starts at home, right? So first tangible step to me would be engagement on different levels. And the first level would be the individual level. How engaged are you in the needs and quality of care and ways to put forth change? So for the for example, the person that posed that question, yes, this has been an ongoing theme, and it's one thing to talk about it, but it's another thing to do about it. So we have to get from the talk to the action. So even something as simple, when I say engagement, even something as simple as self-identifying or identifying with your disability, with the community, from there, then you can, just as Andres said, there are many facets to being a person with a disability, whether that's from an accident, whether that's from birth, whether that's from a chronic condition. So I'm a person with lupus, right? So my immediate disability connect past myself would be to groups and others with that common interest. So starting a lupus support group, being involved with groups, being involved in committees, serving, volunteering to get acclimated to the community and the needs that it has. From there, example today, I went to state, to federal level, participating on discussions for advocacy congressional hearings this spring. And so being engaged, it's not, we have to come outside of ourselves. We start with ourselves, but we move out. Andres taught me this as a mentor. He told me, focus on what needs you have and what way you feeling that need and serving that need and advocating for that need can help the wider community. So I can start with the lupus community, but then I can intersect with women's health, African-American issues. I can take it in different directions. So how do we just stop talking about it? We have to make a conscious effort to do, to act, to register people, to go to these things that Andres mentioned, their health policy, be involved, learn about it, sit in, be at the round table, become a leader. Become a leader.
Thank you, LaShawn. Rani?
I agree with LaShawn. And then, the way I would say, and also I just want to bring back to what Andres said too earlier, which is like people with disabilities, and for me, like non-tokenized, but folks with disabilities that being in decision making, parts of these healthcare systems is a very good actionable step. LaShawn is also talking about what I would call, just to kind of reiterate, is, locus of control, influencing what you have power over, and in that vein, I would even recommend like utilizing diversity, equity, and inclusion goals within your organization, so that your organization is at least creating a baseline about maybe customer satisfaction, treatment, services treatment, disabled versus non-disabled, looking at that baseline and then setting up ways to improve. So that's some tangible thoughts that I have very quickly. Thank you.
Thank you, Rani. Andres?
Well, look, I think it begins with recognizing that these issues are problems that can be solved. And also, a hard look at ourselves, people with disabilities, and what we've done historically to enable healthcare providers to continue to discriminate against us, but not providing us accessible care or inclusive care. So in terms of tangible things that can be done, three things. Number one, the first call to action is know your legal rights. Know what those laws, the three federal laws that we talked about, the Americans with Disabilities Act, the Rehabilitation Act, and the Affordable Care Act. Know what your rights are under those laws, because that's the predicate to you being an effective patient advocate. Number two, second call to action. Establish a relationship with your local hospital. Speak to the administration about the need to have people with disabilities represented on their board, as I mentioned before. Offer to identify candidates. Also establish, an auxiliary board made up of community members representing different categories of disabilities to meet with the administration on a regular interval to provide feedback on services and program. And at the very least, convince them to hold a listening session to receive constructive feedback from the disability community that they serve. And then finally, have the resolve to exercise your legal rights when all of your advocacy fails. Again, we have to assume part of the responsibility for the inequity that continues to exist because of our inconsistent or sporadic enforcement of our legal rights.
Thank you, panelists, very much. So what I'm hearing is we obviously have to move from talk to action. There needs to be engagement on all levels. We need to know our legal rights, as Andres just has stated, and really recognize that issues can be solved. I really like that and appreciate that statement. So some things we can all do is, again, including focusing on what needs we have. That's going to help us lead to filtering into other areas and to really intersect all those areas together. So this leads me to our final discussion point for today, which is another important part of the conversation is highlighting what work is already being done so that we can really rally support around those initiatives. So could each of you share a project you're working on currently and how it's contributing to progress in healthcare equity? Andres, I'm going to have you go first.
So I am proud to say that at the National Council on Disability, we're putting the final touches on a comprehensive health equity framework for people across all categories of disability, which we hope to publicly reveal in the next couple of weeks. And then once we do, if you would support our framework and initiative by contacting your federal representatives, your congressmen and senators, asking them to support our framework and push for health equity for people across all categories of disabilities. The framework really addresses many of the things that we've talked about here, and that is, the need for cultural competence training for physicians and other healthcare providers. The Affordable Care Act that was passed back in 2010 required the Secretary of Health and Human Services to develop model curricula, and that has not been done. And so we're trying to meet with the Secretary of Health and Human Services to get that completed and then to mandate the use of that model curricula in all schools, all medical schools and allied healthcare professional schools as well. Other components of our curricula include changes to the regulations for the Americans with Disabilities Act and the Rehabilitation Act to clarify what the obligations are of healthcare providers, to the extent that they're hiding behind the just general and broad language that exists now in those regulations. If we need more clarity to be more specific, so that healthcare providers no longer hide behind that general language. But there's a number of different other components. There's 26 specific components of our healthcare initiative that I'm proud to say that if we're able to get even a fraction of that implemented, will make a significant difference in the quality of healthcare that we receive, and then in the lives of people with disabilities. So stay tuned. You'll be hearing more about this in the next couple of weeks.
I was just going to ask, is there a time frame in which we'll be hearing more? But you just responded to that question.
Yeah, absolutely.
That's great. LaShawn, how about you?
Well, a current project that I'm working on is called Popular Opinion Leader. And the point of this project is to engage minorities and people with disabilities to participate in clinical trials. The idea behind this project is that individuals may trust, value, and respect a leader from the community and receive the information about the clinical trial more receptively than from someone that they have no relationship with. This can kind of help balance the health equity, because the disability community needs to be included in studies so that we know and trust that the results or the projected advances or outcomes apply to us as well. When we are, excluded from that, we don't know. You can take COVID as an example. Some chronic conditions were highlighted where others were not. when the clinical trials were done. We don't necessarily know that people with disabilities was included in that. We don't know. There's some data, but when we are participant, when we are engaged, when we are included, when we are active, then that kind of leads down to, as Andra said, we have to bear the responsibility to help decrease this disparity and these gaps and this inconsistent care. So this POL project is something that I've been doing for maybe a few months now. And I think it's going to go on into next year. So I'm very happy and proud of my accomplishments with the work that I'm doing for that, to help engage people in the disability community to get involved with clinical trials.
LaShawn, will you state the name of that project again for all of us?
Sure. POL, Popular Opinion Leader.
Popular Opinion Leader. Okay. Thank you. Ronnie, how about you? Would you share a project you're currently working on?
Well, I mean, it's not particularly a project, but, you know, as a Illinois Department of Human Services Division of Rehab Services, it handles the operations of our home and community-based waiver program for the state of Illinois, for folks who have traumatic brain injury, for folks who have HIV/AIDS, and then folks who have physical disabilities under the age of 59. Under my directorship, this program has grown 6%. And it's important for this program to grow because it's set by the federal government as an alternative to people with disabilities being institutionalized in nursing facilities. And when we have people with disabilities getting access to home and community-based services, it is a way for people then to have control over their environment, to have control over who takes care of their bodies in their own home and take care of their home, which then allows them, with that kind of, you know, control over their own space, that they can make more powerful decisions about, you know, who's in charge of their body at the work, at your healthcare system, and stand up for yourself and just assert yourself and be like, I have been discriminated against, and so therefore I'm going to exercise my rights, as Andres has talked about. So I am going to continue to press for this program that allows for people with disabilities to live outside of institutions to grow and flourish, so that people with disabilities can continue to have that kind of self-control.
Thank you, Ronnie, and thank you, panelists, for sharing all that information with us today. Those are really important projects and best practices that are being addressed and looked at. And I really feel that in conjunction with the action steps you shared, we can all have an impact and make a difference. So panelists, thank you for your insight, for your stories, your conversations. I am truly honored to have had this time with you today. I continue to be struck by the complexity of this topic of equity in healthcare. And yet I'm really empowered moving forward to be a part of the collective voice that we have brought together today in this platform via the event virtually. I look forward to hearing all the updates from you in regards to your initiatives and projects, and continued action steps moving forward, so that we can continue to work on this issue and make sure that everyone feels valued in their lives and in their healthcare. So at this time, the panelists and myself will be exiting the screen, and Claire Killey will be rejoining us with closing remarks.
Thank you so much again to our panelists, Andres, LaShawn, and Ronnie. Thank you to our moderator, Kristen Kroc, and also Josephine Breilich of Aspire, who's managed tech planning and support for this event. Mostly, we want to thank all of you for taking the time to join us today to engage on this important topic. We will be following up, as mentioned, to share a recording of today's event as soon as it's available. And we received so many incredible questions in the chat today that we're going to sift through, make sure we get answers to those, and include all the relevant resources that we can in our follow-up correspondence to all of our guests today. So I do also want to extend an additional thank you to our partners, excuse me, Disability Lead, for their collaboration on this event. As I mentioned, please know that Disability Lead is currently accepting applications for emerging leaders with disabilities to join their new class of fellows. You can learn more about that via the link in the chat.
disabilitylead.org/apply.
We do hope that all of you are leaving today feeling empowered with new knowledge, insights, and motivation to act. So in closing, just want to again thank you all for your commitment to inclusion, and we hope that you'll stay connected with Aspire and hope that you have a wonderful day. Thank you.
Blue text on white background, building disability equity in healthcare. Presented in partnership by Aspire and Disability Lead. Learn more at aspirechicago.com. Speakers. Host, Claire Killey, Aspire. Moderator, Kristen Kroc, Aspire. Panelists, Andreas Gallegos, the National Council on Disability, and Robin Salomon and Pat Limited. LaShawn Garola, Rush University Medical Center. Ronnie Patrick, Illinois Department of Human Services, Division of Rehabilitation Services. Event Planning and Accessibility. Technical Assistance, Josephine Brylack, Aspire. CART Services, Efficiency Reporting. Video editing and audio description, BridgetMelton.com. This program was made possible thanks to generous support from the Fred J. Bruner Foundation.